Thank you for having me, and thank you all for sticking through till the end of the day and the very last talk on almost the end of the conference. So I'm delighted to be here as part of this panel and kind of get things rolling for this session. So I don't have any conflicts of interest, and just kind of to give you an outline of what I'll be talking about today, I'm going to go over very basic, probably shouldn't even qualify as the term basic, overview of genetic disease, talk a little bit about genetic counseling and a really important part of genetic counseling, which is documenting pedigrees and family history, and then utilizing that pedigree and family history in your clinical practice, and then moving into some case examples that I think really will drive home the value of that tool, and using that to integrate genetics as a first-tier level into your practice. And then what does that look like? And what does that look like in the United States? Is different in every center, but I think what that will look like across the world is also going to be different. But I'll give you just a few ideas of what I think the service delivery models for genetic counseling and how that can tie into hemophilia care. So I think it's almost illegal to do a talk on genetics and not have some kind of schematic diagram like this in your presentation, so that's really why this is in there today. I'm not going to go into the basics of biology and genetics, but really just want to point out two main things about a genetic disease, and one of those is that it is a lifelong condition, and the other is that it's a familial condition. And I think probably no one in this audience would argue with me on those topics, but I think it's important to really point out, because that's what makes not just hemophilia, but any genetic disease different than a non-genetic disease or diagnosis. As genetic counselors, that's actually how we're taught about diseases, that's how we're trained to think about diseases, and so I think our profession has a lot of unique perspective that can be offered to a specialty like bleeding disorders, where you're primarily dealing only with inherited conditions. So what is genetic counseling? A common definition that you will see is that genetic counseling is the process of helping people to understand and adapt to medical, psychological, and familial implications of genetic contributions to a disease. And the word I want to focus on there is that it really is a process. It includes collecting and interpreting information. It includes providing a lot of education to patients, to families, to other providers. Identifying psychosocial issues that may be kind of coinciding with this workup or diagnostic process, and how that's affecting not only the patient but also the family members, and then really promoting the patient to have informed decisions that they're making about their own health care. So for the next section of the talk, I'm going to focus on one of the most important pieces of information as genetic counselors that we collect, which is family history. So just kind of as a brief show of hands, people in the audience that are involved in their care for patients document family history. How many of you are involved with documenting history? Show of hands. Okay, most people are not raising their hands, but hopefully someone at your clinic is doing that. For those of you who are documenting it, are you doing it within your note as words, or are you drawing pedigrees and kind of visual pictures? So how many are using words and kind of writing paragraphs about family history? Anybody using pedigrees or electronic diagrams? Great. Okay, so actually I'm glad to see that. So going a little bit into why I think documenting a pedigree as a picture form is actually better than writing it out in using words. I think a picture, as they say, a picture is worth 1,000 words. It really is a clear and succinct way to document a family history. It's easily translatable, so if you're documenting a family history by words, sometimes it can get a little confusing if someone else picks up what your words are and tries to make sense of them. But if you draw it as a picture using the tools that are out there, it's easy for one provider to pick it up and know what you got from that family when you were documenting the history. It also can help you kind of identify patterns that may be arising in the family that may not be as clear if you're just looking at words, and can really be used to inform your risk assessment. So some tips that I want to give everybody for documenting a family history. First, I would suggest considering using standard pedigree nomenclature. So there is standards out there, and I'll give you a resource where you might be able to look that up and integrate that into your clinic. It's really, really important, I can't stress it enough, to clarify the actual biologic relationship. So if someone tells you that they have a cousin, that you're asking how that cousin is related to them, because it may be a second cousin. It may be someone who's not related by blood, but they call a cousin. And so it's really important to not just ask for the name of how they refer to those people, but really what's the biologic relationship of that family member to the individual who's sitting in front of you. When you take a family history, even though you are seeing patients primarily for their bleeding disorder, it's important to still ask history about general health in the family, because there may be something that ties into the bleeding disorder, but there also may be something going on in the family that deserves referral to another specialty service. And then when you're documenting a family history for a specific disease, like if you're seeing a patient for hemophilia, not just asking the question of, does anyone else in your family have hemophilia, but really asking specific questions to tease out the details of what might be going on. And I'll go over a slide that has some suggestions for how you may do that. It's important to be open and ask about pregnancy. I think a lot of people may be a bit more timid about this question because they don't want to offend a woman and give her the impression that she looks as if she's pregnant, but really that can change what you're going to provide that individual information with. And so, rather than saying, are you pregnant? You can say, is there a chance that you may be pregnant now or in the near future? And that just opens that dialogue up for them to share that information, because that is drastically going to change what options you may give them and what care you may provide to them. Documenting the cause of death, so not just if an individual is deceased in the family, but why did that individual pass away? What age were they when they passed away? Because there may be clues within that information that can tie into why you're seeing the patient or what assessment you may be giving for the family. And then my last tip is to update a pedigree frequently. These are not static pieces of information. When I first started working in our clinic, I thought it was going to be very redundant for me to update the family history when patients came in on an annual basis. And then I started doing it, and I was wishing I was doing it more often. People pass away, new babies are being born, people are pregnant, there's new marriages, new people are having symptoms, being diagnosed with conditions. So really, I would suggest any time that you're face-to-face with a patient, just asking the question of if there's anything new in the family history can be very important. So I'm going to give you a resource for standard pedigree nomenclature, and then we'll talk a little bit more about what questions you might specifically ask to tease out the bleeding disorder in the family history. So I know this is a busy slide. You probably cannot see it. It really is up here as a reference. This is from the National Society of Genetic Counselors, which is the professional organization for genetic counselors in the United States. And this is their document that recommends how to standardly draw pedigrees. So they give you, what shape should your symbol be? How should you shade that symbol? It goes into what do the different lines mean? How do you notate if someone's divorced? How do you notate if there's consanguinity in the family? What if there's a sperm donor? What if there's someone adopted in? There's very specific ways to draw these things so that when you're taking the history and someone else picks that picture up, it means the same thing to them. So I would encourage you to look this resource up and familiarize yourself with the standards that are recommended. When you're targeting the history to the bleeding disorder aspect in the family history, some questions to ask. First of all, does anyone in the family have the same diagnosis as you? Which may seem like a very obvious question, but really being forthcoming and asking that directly. Because patients may not understand the benefit or the value in telling you who these people are. They might just say, yeah, there's nothing in my family history, but if you ask more specific questions, you're going to get more specific information. So does anyone else in the family have the same bleeding disorder diagnosis? Very important. Does anyone else in the family have a different bleeding disorder diagnosis? So you may be seeing a patient with hemophilia A, and if you say, is there a family history of hemophilia, they say no. But then if you say, does anyone else have a bleeding disorder in the family, they may have a cousin or an aunt who has von Willebrand disease. And is that a second diagnosis in the family? Is that a misdiagnosis in the family? If you're not asking that question, you might not even have the opportunity to explore that. Asking specific bleeding symptoms, and not just if anyone else has symptoms, but does anyone in the family have heavy periods? Does anybody have a history of nosebleeds? Really going through what some of those more frequent symptoms that you'd expect to see, what they are. Asking if anyone's ever had treatment. So does anyone else in the family use factor? Does anyone else in the family, have they ever needed a blood transfusion? Some of these things may seem redundant, like you're asking them in different ways, but patients all hear things differently. And so if you only ask things in one way, that might not get you the answer from one patient that it would from another. Asking if anyone's had any bleeding complications. So has anybody had any significant post-op bleeding? Has anybody had any issues after dental extraction with bleeding complications? And then I think what often can get forgotten is, has there been any prior genetic testing in the family? This can be critical in what options are available to other members of the family or what you're able to offer to your patient if you know if someone else in the family has previously had testing. So I would encourage you to ask that question as well. So I think I want to just take a minute to emphasize that taking a pedigree is not a checkbox because bleeding disorders are inherited and so we take a family history. Taking a pedigree is actually a very powerful and free, people like free things, right? Very powerful and free clinical tool, and it can really be used in a variety of different ways to make sure that you are providing the best personalized care that you can for patients and families. So you can use a pedigree to identify the inheritance pattern in a family and inform what your diagnosis or your differential may be. You can use a pedigree to guide what a testing may be appropriate for this family that might not be an option for another family. It can allow you to respond to new developments in the family, to identify what clinical impacts this may have for relatives, and to really elicit educational and psychosocial needs for family members as well. So I'm going to move into a few case examples that I think will just highlight for you how taking the pedigree in these situations really allowed us to provide better care for the family. So the first case is going to emphasize the ability to use a pedigree and the inheritance pattern that you may see in a pedigree to inform your diagnosis. So we had a 16-year-old male who had pronounced bleeding post-dental extraction. He had initial workup before he got to our clinic. Factor VIII level was 8%, von Willebrand level 55, and von Willebrand activity was 50. He was then referred to our clinic, and our clinicians were between the differential diagnosis of, is this hemophilia A or is this type 2N von Willebrand disease? We're going to order all this testing and send it out. And I said, can I go take a family history? And they said, well, yeah, but we're still going to order all this testing. So I went in, I documented a family history just to familiarize yourselves. For those of you who may not know, squares are men and circles are women, and then the lines depict sibships and different generations. So this individual here was the patient, the 16-year-old who had come into us. This would be his mother, her siblings and brother, and then her parents. So in taking the family history, mom tells me, oh yeah, my dad had hemophilia A. Very clearly, she knew the diagnosis. She knew it was factor VIII. And she also has a nephew who has hemophilia A, consistent with an X-linked inheritance pattern, so we don't have to question, was this a totally different diagnosis? And that really changes our assessment for the 16-year-old, right? So by having her father have hemophilia, we know she's an obligate carrier. And before her son ever had any testing, he had a 50% chance to have hemophilia. So when you combine that with the fact that he had a factor VIII level of 8%, the likelihood that it's hemophilia A versus 2N von Willebrand disease is much more increased. So that was the first example. The second example is how taking a family history and asking specific questions can really guide what appropriate testing is available for the family in front of you. So a 2-year-old female was referred to our clinic with a diagnosis of von Willebrand disease. She had an antigen of 28%, an activity of 25%, and she was referred by her neurologist. So we go in and take the pedigree. There's no other family history of bleeding that's reported. We ask all the specific detailed information, but we do note that mom is currently pregnant, which is something that we can help to address with her. We also find out that the 2-year-old has a history of seizures and what's called a 12p deletion, so a deletion of part of chromosome 12. Why is that important? Because for this girl, her deletion of chromosome 12 actually includes her von Willebrand factor gene, and that's how the initial diagnosis of von Willebrand disease was made for that 2-year-old. They then subsequently drew the von Willebrand levels. So for the mom, this actually gives us much better testing options than otherwise we may have had for her. So as you know, during pregnancy, for the mother, we would not likely be able to get a definitive diagnosis because of the variability of von Willebrand levels during pregnancy. But because we had this very specific genetic marker in the daughter of why she had von Willebrand disease, we were able to offer that same 12p deletion testing to mom, identify that she was indeed carrying that same deletion, which means she also had a deletion of her von Willebrand gene. And while we didn't have baseline levels for her, it allowed us to just have a very open conversation with her OB and provider, come up with a plan, and really open those lines of communication. Responding to new development. So this one was fun. There was a 39-year-old who was seen in our clinic. She was a hemophilia A carrier by genetic testing, but she had only ever had a factor level drawn while she was pregnant. So we had recommended after you're pregnant, after delivery, come back in and see us, have a baseline level drawn when you're not pregnant, not on hormones, not breastfeeding. 9 years pass, and she just walks into our clinic one day to get her blood drawn. So she followed up, but it just took her a little while. And so, one of our providers met with the patient to kind of update not just her family history, but her whole history. And really nothing in her family history had changed. So you might be wondering why I'm mentioning this case, but in this example, it was very important actually how the question about pregnancy and family planning was asked, because she told us that her motivation for being tested now was that she was actively pursuing IVF for fertility treatments. And so 9 years prior to that, she had said, this is my only pregnancy, I'm not interested in any more children. And now here she is already going through IVF for fertility issues, and there are options available for family planning that require IVF. So there's something called pre-implantation genetic diagnosis, where once the embryo is formed, you can test the embryo and then only implant back in the embryos that are unaffected. So it's an option that all pregnant individuals or women of childbearing age should be aware of, but especially for her because she's already going through the IVF process. And it is something that she actually ended up proceeding and moving forward with. So case number 4, just to point out how taking the pedigree in a detailed way can identify the clinical implications for relatives. So I think a lot of times we focus on the patient is the person who's sitting in front of us. So this was a 7-year-old with mild hemophilia, factor 8 level, who was referred to our clinic. Someone went in the room first and came out and said, there's no family history, so there's no need for genetic counseling, Michelle, you can go back to your office. And I said, I don't take no for an answer, so I'm gonna go in the room. And in taking the family history and really asking and spending the time to ask the detailed questions, we found out that while there is no diagnosis of hemophilia in the family, the patient's mother's brother, so the maternal uncle, had really bad bleeding post-dental extraction. The mom remembered that he had some kind of abnormal blood screening, that he's prone to a bleed, but he never followed up with that testing. But again, that changes what her likelihood to be a carrier may be. If he truly had hemophilia as well, she would be an obligate carrier. On top of that, she shared, based on our questioning, that she had an upcoming knee surgery in 2 weeks. And so as a result of that, our providers at the clinic scheduled her as a patient, evaluated her, drew a factor 8 level. She had a level of 28%, and so they were able to work with her surgeons to make sure that she had an uncomplicated surgery based on the recommended plan. And then in continued follow-up with the family, the uncle actually did end up going and having testing because he understood the value and the importance of it, because his relatives were seen at a hemophilia treatment center. And so, another relative was ultimately diagnosed just by asking the right questions in the family history. And then my last case that I'll go through is using the pedigree to really identify how you can support the needs of the rest of the family as well. So this was a 44-year-old male who came into our clinic for his annual visit, nothing special going on. He's previously had genetic testing, the family variants identified, We went in to update the family history as part of his visit. There was nothing new. Okay, so no changes, nothing new. Again, why am I telling you this case? When I say there's nothing new, there were no new individuals, there were no diagnoses in the family, there were no deaths in the family, but his sister had just recently gotten married. They were thinking about having children, and he said that she was very stressed and anxious about the thought of having a child with hemophilia. So we provided him with contact information for her to reach out to us. She ended up coming in for a clinic visit. And as part of the genetic counseling process, we were able to elicit that really her anxiety and fear was kind of twofold. One was that just the unknown of being a carrier was more stressful to her than if she knew that she was. And that her husband and her had a very different baseline knowledge of what hemophilia was, and that was causing some issues between them as far as plans for children in the future. So as a result of addressing family history with her brother when he came in for his visit, we really were able to help her and her family as well. She had targeted testing. She did find out that she was a carrier. She actually expressed that it was a relief to just have that information rather than live with the unknown of not knowing if this was the road she was going down. And then we also suggested, and they agreed to come in for a follow-up visit together as a couple so that they felt like they both had the same information about hemophilia. So to kind of take a step back again and really talk about how to integrate genetics, and I would say genetic counseling, into your clinic. If you go back to what the definition is, it's the process of helping people to understand and adapt to the medical, psychological, and familial implications of the genetic contributions to disease. That's a lot, and that's not something that one person can do, and I think it really takes a village to get this information to the patient and to the family. So, you go through a lot of different things that you're teaching a new family about, what the diagnosis is, what's the natural history of the disease, what's the science behind it, what are the possible complications they could have. You talk about joint health, who is on their clinical team and who are their important doctors. This list goes on and on and on, and is certainly not all-inclusive. But ultimately, as a team, what we're trying to do is get people from that left side where they have an initial diagnosis of an inherited bleeding disorder to the right side where people understand and are able to fully adapt to what that diagnosis is. And I think one of the really key important pieces of that is the familial implications of the disease, and that you're really not just making this an impact for the patient, but actually for the people and the people that it affects beyond the person who's sitting in the chair in front of you. So what does that look like? And as I said before, it's going to look different everywhere that you go. It's going to look different by the country that you're in. It's going to look different just by the center that you're in, even within the same city sometimes. A lot of that's going to be based on who's on your team, what are your resources, what's your patient population. This is a diagram from the WFH Genetic Counseling for Hemophilia pamphlet that's out there. And you can see that among providers, there's a lot of overlap of what their priorities are and what they're really tasked with as contributing to the team. So what could this look like? So just a couple examples. Some people may hire a genetic counselor, and I think as a genetic counselor, I would say that is the ideal answer, but it's not always the most realistic answer. And so what are some other things that you might consider? You can contract with a genetic counselor that's in your community. Oftentimes a general genetics clinic might be able to provide a genetic counselor for the day of your clinic only, if you're able to help support some of the funds of a position. You can also, if that's not an option, just consider establishing a relationship with either a local genetic counselor or a telegenetics service, to give you familiarity with who you may be referring your patients to so that you can educate them on the current status of hemophilia and they can keep you up to date on the current status of genetics, really just kind of opening the lines of communication and referral pattern. And then you can also, within your current team, delegate and empower the current staff that you have to really fill this void. And I think for a lot of people across the world, that's really what the answer is realistically going to be. But it's important to not just tell someone that they're in charge of it now, but really make sure that they feel confident and have the support and the tools to do it in an effective way. So just in conclusion, as I said at the beginning, I don't think is a surprise to people, but important to just remind yourself of, inherited bleeding disorders have familial implications, and these patients are our patients, but their families should also be considered as well. It's important to take a really good family history and to make sure that it's updated over time. The pedigrees are free if you just take the time to get them, and that they can be really useful in informing your practice. And that genetic counseling can, and I think should, really be an intentional component of the multidisciplinary team. And I want to focus on that word intentional. I think a lot of times people may assume someone else on the team is doing it, or someone else on the team is doing part of it and I do part of it. And if there's really not a clear understanding of whose responsibility it is, that potentially leads to fragmented care for the patient. And so really just having a discussion among your team members of, what do you do for family history? How are you talking about testing options or prenatal options, to make sure that everyone's on the same page and that everything is covered in a way that really benefits the patient. So that's my information. If you're in an area and you don't know how to get in touch with a genetic counselor, you're welcome to reach out to me. I can't guarantee I know someone there, but I have resources where I could try to find a genetic counselor or a genetics individual within your community. If you're in the United States, that link at the bottom is through the National Society of Genetic Counselors, and you can enter your zip code, you can enter a specialty, you can enter a hospital system to search by who may be in your area that you could reach out to and really network with. Thank you.